at least 2:15 we should reach here. 2:15, okay? So enjoy your lunch and have prayer and have a break and come with fresh mind. Thank you so much.
Come, come. I am there only. Sure, sure. This is early pregnancy? Oh, okay. Yes, sure. You want to move there? Come. Come.
Rokeya madam and doing sonography for us. It's very promising.
So we have already discussed about the pre-ovulatory scan, and we actually have started already discussing about the luteal scan, because we know that once the surge has reached its peak and the ovulation occurs, that is when the luteal phase starts. And we all know, as we have and this is a quick revision, that the follicle which is mature, that is going to rupture and will result into a corpus luteum. But the follicles which were suboptimally mature, which didn't have adequate flow, with the LH surge also, they will not ovulate and they will go into a luteinized unruptured follicle. How do you identify a luteinized unruptured follicle? The luteinized unruptured follicle can be diagnosed soon after the surge itself, when the outer margin of the follicle starts becoming hyperechoic and low level echogenicities start developing inside the follicular cavity. Remember that the major differentiation between the corpus luteum and the luteinized unruptured follicle is that when it is a corpus luteum, that is when, because of the ovulation, there is going to be hemorrhage in this cystic cavity, and that will show as either fishnet or honeycomb or fibrin strands, whereas the luteinized unruptured, as it says, unruptured follicle, it will not show any hemorrhage, but because of the theca lutein cells, the fluid becomes very thick, and therefore you start seeing low level echogenicities inside. So presence of the hemorrhage itself tells you it is a corpus luteum. We have already discussed about the changes on the luteal phase in the endometrium and in the uterine vessels, and it is important to understand that the luteal phase assessment can only be done in the mid-luteal phase. Before that, the progesterone levels have not reached a plateau, and unless it has reached a plateau, when it is still in a transit, you cannot document it as a low or a high level. So that is why the diagnosis of the luteal phase abnormalities must be done always only in the mid-luteal phase. And the mid-luteal phase is about 8 or 9 days post-ovulation. If we said that the pre-ovulatory RI tells us about the estrogen level, the perifollicular pre-ovulatory RI tells us about the estrogen level, it is the RI of the corpus luteum which tells us about the progesterone level. The RI of the corpus luteum can be correlated with the plasma progesterone levels, and RI of the corpus luteum can therefore be used as an adjunct to the plasma progesterone assay as an index of the luteal function. And the RI of the corpus luteum should always be less than 0.5. Though what I showed you today was not that impressive, but if you can see this, the corpus luteum RI, the corpus luteum always shows beautiful, beautiful ring of color. You can see it here, shows a beautiful ring of color, and that tells me, yes, the corpus luteum is adequate with a low RI, and there is no problem with the progesterone production. But like we did for the follicle and the proliferative phase, we also need to find out whether this progesterone is adequately acting on the endometrium or not. Is the bioactivity okay? Is the progesterone receptor development is okay? And that is done by looking at the uterus and the endometrium. The endometrium has to be is expected to be completely hyperechoic, and you must see vessels reaching inner layers of the endometrium. Not only that, it is this vessels which is expected to have an RI of less than 0.52. Just to round up the figure and make it easier for you to remember, you can say that the uterine, the endometrial or the spiral vessel RI and the corpus luteal RI both should be 0.5 or less than that. But it is not just the spiral vessels. We know that we also need to evaluate the uterine artery, and the uterine artery PI also should be less than 2.5, which tells me this is an adequate luteal phase. Why adequate luteal phase? It is because of the effect of the progesterone that the RI of the uterine artery falls below what was in the pre-trigger. So in the pre-trigger it was 3.2, here it is 2.5. So that tells me, yes, this is an adequate progesterone effect and there is an adequate progesterone receptor development. So if that is a normal luteal phase, what would be the abnormalities of the luteal phase and how would that be diagnosed? We know that the abnormalities of the luteal phase are luteinized unruptured follicle, and it is a luteal phase defect. If I say luteinized unruptured follicle, as we have discussed earlier also, this is a quick repetition, that it will develop as a result of surge on an inadequately mature or suboptimally mature follicle, or it may be because of inadequate LH surge. Now, and we also know that it starts as hyperechogenicity of the outer wall of the endometrium, outer wall of the follicle, and that will it also be associated with low-level internal echogenicities. As we know, with luteinized unruptured follicles, there is luteinization, so there is initial conversion or a partial conversion of granulosa cells to thicker cells, and it is also going to result into some production of progesterone. So the endometrium, because of that initial effect of progesterone, is going to get compacted, the endometrial thickness will decrease. There will also be a mild hyperechogenicity, but if you put on a Doppler, because the progesterone level after that does not rise, therefore if you put on a Doppler, the vascularity will be scanty, and whatever vascularity is there will be a high resistance flow where the RI will be more than 0.6. So that is, and if you look at the uterine artery PI also, the uterine artery PI also will have, will be more than 3. So this is, uterine artery PI, yes, it will be also be more than 3. So these are the signs which tell me this is an LUF. If we know what is the cause of LUF, which we discussed, what will be the treatment? If I get LUF in this cycle, I must be sure that in the next cycle I do not give a trigger unless I have confirmed the blood flows, and I must assess my trigger agent if I have changed it for its quality, for its temperature control, and whether it has been taken correctly or not. So that means that a luteinized unruptured follicle once is not going to be a luteinized unruptured follicle in every cycle, and if you find a luteinized unruptured follicle in one cycle, you can definitely correct it in the next cycle, and you know exactly what you need to do for that. But that also makes us realize that whenever there is a multifollicular development, that is when the follicles which are mature will rupture and convert into the corpus luteum, but we have to remember that the suboptimal follicles will convert into LUF, and remember that it is only one healthy corpus luteum which is required to support the luteal phase. So whenever there is multiple follicular development, presence of n numbers of luteinized unruptured follicle in presence of one active corpus luteum is no problem at all. If it is only corpus luteum, it is only luteinized unruptured follicle, that is a problem. But one active corpus luteum and the rest are LUF, that is not at all a problem. The second problem with the luteal phase is, of course, the luteal phase defect. And we know that the luteal phase defect can be because of two reasons. It may be because of inadequate production of progesterone, or it may be because of inadequate progesterone receptors in the endometrium. Whenever it is because of inadequate production of progesterone, there will be a corpus luteum. There is a cystic lesion which has hemorrhagic echogenicities, which does not have hyperechoic walls, and still if you put on a Doppler, it will show scanty flow. So that tells me that yes, it is a corpus luteum, but it has inadequate flow. That means that it is an inadequacy of the corpus luteum. So don't confuse it with LUF. I repeat, LUF will not have any hemorrhagic echogenicities. But here also the production of progesterone is less, and therefore the endometrium appears thin, non-hyperechoic, and it also shows, if at all vascularity is seen, it is a high resistance vascularity, and along with that the uterine artery PI is also more than 3. But if you find inadequacy of the corpus luteum, the treatment to that is HCG as a luteal support. Remember that if you want a good luteal phase, apart from progesterone, HCG as a luteal support is a time-tested medicine. It is very effective even in recurrent pregnancy losses to support the pregnancy. We give HCG to all our patients along with vaginal progesterone as a luteal support, day 5, day 9, 5000 IUI. 5000 IU. So day 5, day 9 post IUI, 5000 IU. And it works very well. If you don't want to give 5000, you can give day 2000 international units, day 3, 7 and 10. So this is an additional luteal support that we will give in the next cycle, and that works. If at all, 3, 7, 10, 2000, 5 and 9, 5000. The second possibility is that there will be a luteal phase defect because of inadequate progesterone receptor development. So in this cases, the corpus luteum is absolutely normal, but the endometrium, in spite of normal corpus luteum, in spite of normal corpus luteal flow, still the endometrium will be thin, non-hyperechoic, scanty flow, and the uterine artery PI will be high. If I say scanty flow and if I say high resistance flow, there is a table which shows us normal spiral artery RI in a normal case in the mid-luteal phase, and this is the gradient between the two in cases of LPD. That means you get a very high resistance flow because the progesterone is not being perceived by the endometrium. If this is the case, what is the reason? Whenever you see that there is inadequate progesterone receptor development, remember that the development of the progesterone receptors is fully dependent on the estrogen priming of the endometrium. So, if the estrogen priming of the endometrium is inadequate, only then there would be progesterone receptor defect. What do I mean by estrogen priming, and how much, and how do I evaluate whether the estrogen priming is adequate or not? If the duration of estrogen exposure to the endometrium, that means from the day of dominance till the day of trigger, if the follicular maturity takes 4 to 6 days, that is a sufficient estrogen exposure to the endometrium. And on the day of the trigger, if you have checked that the follicular flows are adequate, that means estrogen level is adequate. So the duration is adequate, the amount is adequate. That tells you the estrogen priming of the endometrium should be adequate. That means inadequate estrogen priming can be resulting from given a trigger before the follicle is mature, or the follicle rupturing on its own before it achieved the PSV, or it may be because of fast development of the follicle. That means the follicle, instead of growing at 2 millimeters a day, it's growing at 3 millimeters a day, or even faster. Sometimes it does happen. You've seen a follicle today which appears like 12, 13, and day after you see and it's ruptured. So premature rupture or fast development of the follicle will lead to shorter duration of estrogen exposure, and that is also one of the important reasons for inadequate estrogen priming and therefore a progesterone receptor defect. That means if I find inadequate progesterone receptor development, the first thing I will check is how was my stimulation protocol and how was my proliferative phase. Did the follicle rupture after I had seen the flow? How many days did it take? Therefore, whenever you have a follicle on a baseline scan which is already 10, 11 millimeters, that means already have achieved dominance, that means it's an early recruitment of the follicle. In these cases, because the follicle has already become FSH sensitive, if you start FSH then with your routine dose, that is when the follicle will mature very fast because the endogenous FSH is also high. Yes? Therefore, it is in these cases where you find early recruitment of the follicle. That is when you have to start with one dose lower than what we will understand by the baseline score. So that will delay the growth, that will slow down the growth of the follicle by 1 or 2 days, and therefore there will be adequate estrogen exposure, adequate duration of estrogen exposure, and then you can give a trigger when the follicle matures. So that is the treatment if you have inadequate progesterone receptor development. But there is one cause still there. Your proliferative phase may be absolutely normal, your ovulation induction is normal, but unfortunately, during the proliferative phase, the endometrial flow has not developed. If the endometrial flow has not developed or has developed very late, in those cases, adequate estrogen, though it is produced, it is not delivered to the endometrium. And therefore, also it may result into progesterone receptor defect due to inadequate estrogen priming, and therefore in those cases you can add anything that can improve the endometrial vascularity like aspirin or sildenafil or nitrogen patches or so on. Remember, never ever add estrogen to a stimulated cycle. When you are adding estrogen to a stimulated cycle because you want to improve the endometrium, but the endometrium is bad because the endogenous estrogen is either not adequate or it is not bioactive. That means the fault is with the follicle. So ideally you have to treat the follicle, make it better. If you are on CC stimulation, move to letrozole with gonadotrophin, or you are on the gonadotrophin, you may have to change the dose, but very important thing is, when do you add LH? Of course, we will discuss this more with the baseline scan, but if you have a follicle which has grown beyond 14-15 millimeters but does not show flow and everything else looks normal, that is when you need to add 1 or 2 shots of LH, and that will improve the vascularity and that will improve the quality. This is only because of the polymorphism. So, very important to understand that why are we doing luteal phase scan. When the patient fails to conceive, that is when we are confused, we are frustrated, patient is frustrated. But what to do, we do not know. So every cycle the patient doesn't conceive, we keep on adding drugs to the luteal phase. Because everything till the day of surge we have seen. But we keep on adding drugs to the luteal phase. And finally, after 2 or 3 cycles, patient conceives without all those drugs. She might have conceived even without those drugs, but you feel that she has conceived because of those drugs. Unfortunately, all the following patients will get the entire list of drugs every time. And then even if that patient doesn't conceive, your frustration has no limit because you don't understand what went wrong. Therefore, the luteal phase assessment is essential. If the luteal phase is normal, that means everything that has been done and happened during the proliferative phase is all normal. Don't change anything, because the human reproductive endocrinology and the physiology is such that it needs to stabilize itself when you are giving exogenous medicines, and that may take 2 or 3 months. So if everything is okay, don't change anything. Luteal phase is normal, continue the same protocol for 2 or 3 cycles and the patient will conceive. But if you find any fault, you know what to do. If you find that the luteal phase is abnormal, you will find. So this is the scan that we do to find out what should be the gonadotrophin dose to a patient. It is to assess the ovarian reserve and the response. Ovarian reserve and the response are the 2 terms which have been used for years together as interchangeable terms. But we have to understand that there are 2 separate things. Where reserve tells you about the number of follicles that will develop at the end of stimulation, it is the response which tells you how much push or how much dose of gonadotrophin these patients will require to produce those number of follicles. That means that the number of follicles that the patient will grow, which depends on the number of antral follicles and the ovarian volume, it is the response, the dose, the daily dose of gonadotrophin required will depend on the amount of flow in the ovary. Why? Because if the flow to the ovary is more,
that is when more percentage of total gonadotrophins present in the patient's blood, whether it is endogenous or it is exogenous, will flow into the patient's ovary every cardiac cycle. And therefore, as we said, FSH has to reach the antral follicles to make them sensitive to FSH. You remember we talked in the morning? And it is during this antral follicle phase that the follicles, they do not have vascularity. The FSH reaches those follicles by the way of diffusion from the stromal vessels. So there should be adequate amount of stromal flow so that sufficient amount of FSH can go into the antral follicles, which we call FSH threshold, right? So to reach that FSH threshold, if the flow to the ovary is more, because more percentage of total gonadotrophin in the patient's system flows into the ovary every cardiac cycle, the threshold will be reached easily. And therefore, the total amount of gonadotrophins required for that patient will be less. Whereas, if the total flow to the ovary is less, that is when less percentage of total gonadotrophins present in the patient's blood is going to flow into the ovary every cardiac cycle, and therefore to reach that threshold, you have to put much more into the patient's system. Therefore, the patient who has less flow in the ovary is a poor responder, and the patients who have more flow in the ovary is hyper responder. We all know that we have seen patients with multiple follicles but not responding. You have to give them higher doses. And we have seen patients with low reserve ovaries, 2, 3, 4 follicles, but you give just 2 or 3 shots of gonadotrophins and they produce good follicles. So it is very important to understand both, that whenever you want to evaluate or whenever you want to calculate the dose for a patient, dose of gonadotrophin for a patient's ovulation induction, it is important to look not only at the number of antral follicles and the size of the ovary, it is essential to also look at the flows, and there is a literature evidence to that too. Measurement of the ovarian stromal flow in the early follicular phase is related to the subsequent ovarian response in the IVF treatment. These are 3D power Doppler parameters. If they are high, the patient is a good responder. If the levels are low, the patient is a poor responder. Even in patients with endometriosis, where you usually expect a poor response, if those patients, they still have a good stromal flow, they may still respond well despite what is the size of the follicle. And even if you are not using a 3D power Doppler and you are using only 2D also, the ovarian stromal PSV, even after pituitary suppression also, that means even in the cases who are down-regulated, it is predictive of ovarian responsiveness and outcome of the IVF treatment. From the literature evidences and our experiences, we have found that the patients who have an ovarian stromal RI of more than 0.7 and the PSV of less than 5 centimeters per second, they are poor responders, whereas if the RI is between 0.6 and 0.7, the PSV is between 5 and 10 centimeters per second, these patients are normal responders. And if the RI is less than 0.6 and the PSV is more than 10 centimeters per second, which is usually found in the PCOS patients, these are the patients who are hyper responders. That means, and we have already discussed with the live scans as to how to measure the stromal flow. Just a quick revision. You would switch on, you would locate the ovary, you will switch on the Doppler. Once you have switched on the Doppler, then you will scroll across the ovary to look at the vessels. When you find a vessel which is seen, vessel or vessels which are seen in their long axis, vessels because it may be ovarian artery and it may be also ovarian branch of the uterine artery. Sometimes they are spiraling over each other, sometimes they are lying side by side. So find out where you find these vessels which are seen in the long axis and can be seen even outside the ovary, extending outside the ovary. Consider that as a hilar plane. From there, scroll your probe onto both the sides. And you are seeing vessels. You are not seeing hilar vessels now, and you are seeing those small vessels in the stroma. They should be away from the follicle also. And the brightest one, the flows can be measured in any of the brightest ones. That side, or even on the other side across the hilar plane again. So you can measure the flow in any of those. If you find multiple bright vessels, you can measure the flow in at least 3 vessels and find out the best combination of lowest RI and the highest PSV. That tells you this is your decision maker value. You have to do this for both the ovaries, and that tells you what would be the daily dose required for the patient. But it is not just that. As we discussed, it is also the reserve of the ovary. We know that we want to measure the reserve of the ovary. I did tell you that we will count the antral follicles and we will measure the ovarian volume. The antral follicles we have already done when we were doing the baseline scan. You locate the ovary, scroll the probe so that you are not seeing the ovary, and then come back in the same direction, eyeball and count the number of follicles. Now, as long as the number of follicles are up to 12 to 15, that is when, whether you are using this method, which is scrolling across, or you are using a 3D method, both are equally reliable. But if the number of follicles are more than 15, that's when the human error, chances of human error increases, and that it is in those cases that we would suggest you would do a sono-AVC. But sono-AVC is required only if you want to do an IVF. If you want to do an IUI, sono-AVC is not required. For the IUI cycles, we are not going to produce more than maximum 2 or 3 follicles, and therefore it is sufficient to decide the dose. It is sufficient to know that the follicle number is less than 5, 5 to 10, 10 to 15, 15 to 20, or more than 20. So their eyeballing is just perfect. But when you want to do an IVF, especially in the patients who have more than 15 follicles per ovary, that is when you may do a sono-AVC, and this is required because if your stimulation protocol is optimal, the total number of follicles that you will develop with your stimulation protocol will be 60% of the total antral follicles. That means that if you have, say for example, 40 follicles, you will produce about 24, 25 out of it, but we know that ideally we should not produce too many follicles in any ovary, because that is not only injurious to our health, it may lead to risk of life, and moreover, what will you do with them? They are not required. So therefore, and moreover, the higher the number of follicles, of course, we are going to do a frozen transfer in them, so the progesterone is not going to affect. By chance, you have to do a fresh transfer. With the high progesterone, the estrogen-progesterone ratio in the luteal phase is also affected, which would affect the pregnancy rate. So ideally, the literature also mentions that 8 to 15 follicles, if you produce, it's a good result. So in those cases, you may have to decrease the dose. And therefore, it is essential to count the antral follicles correctly. I know the question would be, AMH? We don't do AMH. If you are going to do an IUI, no AMH is required, because what is the number of follicles you want? 2 or 3. If you do a scan and if you see 2, 3, 4 antrals, more than enough, you don't need anything else to do. But if you are going to do an IVF, again, then also AMH practically is of no use at all. AMH is only important, one, when you want to document the patient as having almost 0 ovarian reserve, and you want to tell her you might require a donor, we cannot work with your follicles. Even when the number of follicles are sometimes 4 or 5, but the AMH level is very low, it is a possibility that there may be a poor quality follicles. It is in this cases that it is always better to opt for IUI rather than IVF, because doing IUI selects the best quality. It is a nature's selection of the best follicle, and therefore the chances of pregnancy are much, much better. Moreover, if you look at that, those evidences which all say that whether you do AFC or AMH, it is not going to make any difference practically. And even if you do AMH, are we going to ever start stimulation without doing a scan? No. So why not depend on our own abilities rather than depending on the lab technician's abilities, isn't it? So, of course, and the expense is also important. So that is why, and let's look at the evidences. Number of retrieved oocytes correlates with the antral follicles and the ovarian volume. Multivariate analysis has confirmed that AFC represents the most useful ovarian reserve marker to the controlled ovarian stimulation. In all the studied groups, as the number of mature follicles retrieved increased with the increasing AFC. AFC is considered to have best discriminating potential for the poor ovarian reserve patients compared to the total ovarian volume and all the other hormones. Whether you are using AFC plus AMH or you are using only AFC for poor reserve patients, both the models are equally efficient. A meta-analysis now which is considered the highest level of evidence, and for the poor ovarian reserve patients where we know this is the only group where we are much more concerned about AMH rather than anything else. Even there it is mentioned that AMH has at least the same level of accuracy and clinical value for the prediction of the poor reserve and non-pregnancy as AFC. That means, according to that meta-analysis, AFC is even better than AMH. Even in the hyper-reserve patients, high-reserve patients, AFC is also used to predict the hyper-reserve and thus using safe and successful stimulation regimes and to prevent OHSS. Both AFC and AMH are accurate predictors of excessive reserve to ovarian hyperstimulation. In one of our own studies where we compared AFC and AMH for the two groups, the normal controls and the PCO patients, for the two end results, the number of oocytes retrieved at the end of ovarian, so number of oocytes retrieved on ovum pickup and the follicles larger than 12 millimeter on the day of trigger. Because even the follicles larger than 12 millimeter on the day of trigger, they would all give you fertilizable oocytes. So these are the two end results which were selected, and we found that for both the groups, both the markers, for both the end results did not show any statistically significant difference. That means whether you are using AMH or you are using AFC, the results, your accuracy, your prediction of the reserve is just the same. Therefore, all practical purposes you can avoid the assessment of AMH. Even in the PCOS patients, it is mentioned in literature that AMH is of value in anovulatory patients, whereas AFC is effective in all phenotypes, whether it is oligoovulatory or it is anovulatory, and therefore it is a better tool to assess the ovarian reserve or even in the PCOS patients. Even in patients with endometriosis, the literature does mention that for the patients with endometriosis who are not operated, age and AFC, but those who are operated, only AFC is the marker for the ovarian reserve. And then both alone or in combination, they have the same predictive power. So why do both? You can avoid AMH therefore and just do an ovarian antral follicle count. And of course, if you want to, you can also add the ovarian volume, because we know that the smaller ovaries, they have lower reserve and they may result into poor response and cancellation of the cycle, whereas larger ovaries may be PCO and it is a risk of OHSS. So that is, and moreover, the studies have also documented that it is the follicle number between 2 and 6 millimeters which is significantly related to age and also independent of age to all the ovarian reserve tests, suggesting the number of small antral follicles represents the functional ovarian reserve. There are n number of evidences. If I keep on showing you, it will take us at least half an hour to go through them all. But we know that AFC and ovarian volume and the stromal flows are good predictors to decide the daily dose of gonadotrophins, and since they do not even change after a short-term downregulation, therefore you can use them for your IUI cycles, you can use them for your IVF agonist cycles, and you can also use them for your IVF antagonist cycles. Apart from this, what would affect the daily dose required? Of course, we all know whatever the other parameters, the age is one single and very important factor which may affect the requirement of FSH for the patient, and the second is BMI. So we can take those also into consideration. That means now we have the 6 parameters which can help us decide the daily dose of gonadotropins. And we did several studies starting from about 2003 to 2011. In 2011, we came out with a few parameters of these values which would tell us higher or lower doses required. But still, to be more specific, after that we started a new study to make the stimulation protocols easy and easily calculable, and that is when, using the same 6 parameters, we developed a baseline scoring system. This was published in 2016, and when it was published then, it was based on 1570 IUI cycles and 350 IVF cycles, and it resulted into a 0 OHSS. In fact, let me tell you that we have, even when we were not using this baseline scoring system, as I told you, with our studies where we had just simple values which would tell us these are the patients who would require higher dose or lower dose, even then we never had OHSS. So I have practicing in an infertility center for since 1999, 25 years now. I have not seen a single case of OHSS, in spite of the fact that all our cycles, even IUI cycles, are gonadotropin cycles. So this definitely is an excellent way of deciding the stimulation protocol, but this made the things even more easier. After that study, we continued the study further. It is a multicentric trial going on. We have finished more than 7,000 cases, 0 OHSS, 0 cancellation of the cycle, no conversion of IUI to IVF, no conversion of IVF to IUI. So it is a very foolproof and a very effective method, provided you have measured your stromal flows correctly. So if you just learn to do that, anything, depends on the case. If we have more than 3-4 blastocysts, we would do frozen. If we have less than that, we would do fresh, whatever it is. So, but the results that I'm talking about is only about fresh cycles. We have not included the frozen cycles in this because we wanted to evaluate our stimulation protocols. So what is to be done is this, and it is very, very simple. You only have to do a baseline scan. On the same day, you are going to document age and BMI. After that, you would write down, you would find out the enteral follicle count, volume, ovarian stromal RI and PSV. If you are going to do an IUI cycle, only the ovary which has better flows is to be taken into consideration for the decision. And if it is an IVF, you take a mean of 2. Put the values into the table. Say, for example, there is a patient who is 32 years of age, who has a BMI of, say, 29, has AFC of 7, ovarian volume of 6 cc, stromal RI of, say, 0.6, and the stromal PSV of 4. That means her score comes to 3 and to 5 and to 7 and 3, 10 and 3, 13 and 2, 15. Yes? Now, depending on what is the score, there is a prefixed dose, whether it is an IUI cycle, it is an IVF fresh transfer cycle, or it is an IVF frozen transfer cycle. This dose, at the most, you might have to increase the dose once, but otherwise most of the cases, in more than 80% of cases, you don't have to change this dose, and this takes you to the mature follicle and the good endometrium. So how do you follow up the cycles? You know what is the baseline score, we know what is the dose depending on what is the treatment, and then we start stimulating the patient. Say, for example, we first talk about the IUI cycle. Whatever protocol it is, I repeat, if it is oral ovulogen cycle, you don't have to do a baseline scan. But if it is a gonadotropin to be used, that is when you need to do a baseline scan. And baseline scan done once works for at least 6 months. That means only when you convert a cycle from IUI to IVF, you will have to repeat it. Otherwise, it is to be done only once during the treatment. You don't have to call the patient every time on day 2. So that is important. Now, if you are doing a gonadotrophin cycle, whether it is a letrozole plus gonadotrophin or only gonadotrophin cycle, the dose remains the same. The daily dose remains the same. Only the number of days of stimulation decreases, right? So what you do is, you are going to do a first scan. You are going to do a first scan on the day you are going to start gonadotrophin. Yes? And on that day, as we have discussed earlier also, if all the follicles are smaller than 10 millimeter, you directly call them after 5 days. When I say less than 10 millimeters, we put a flow and we confirm that they are not dominant. Right? That means no dominant follicle directly after 5 days. But if there is already a dominant follicle, you know that they have FSH receptors and they are going to grow at a rate of 2 millimeters a day. So accordingly call the patient. If the FSH receptors are already been developed, that means there is no chance that it cannot respond. It is going to respond 100%. So in that case, no response is not an option. But here, when all the follicles were smaller, and you call them after 5 days, and if there is no response. When do you say it is no response? When do you say it is no response? When there is no follicular growth and there is no endometrial growth. Only then you call there is a no response, because even in the absence of follicular growth, if the endometrium is growing only because estrogen is secreted, and estrogen is secreted because FSH is acting on the granulosa cells. So FSH is, if it is acting on the granulosa cells, in the next 2 or 3 days the follicle will also start growing. So if one of the two is growing, your drug is effective, don't change the dose. You understand my point? And therefore call them after 3 or 4 days depending on the follicular size. Yes? But if both are not responding, which means the patient is not responding, and the primary score was less than 10. Less than 10 means low AFC, low volume, high RI, low PSV, increased age and increased BMI. That means poor reserve, poor responding patient. In those cases, add 75 international units of RFSH on the same days. These all doses are RFSH. I will, if you want to, I will show you the conversion for the urinary also. So you add 75 international of RFSH on the same day, 5th day of stimulation. But if, and again call her after 5 days, because the follicles are still smaller than 10 millimeters. If the primary score was between 10 and 20, that means it is a normal reserve, normal responding patient. You are seeing on day 5 of stimulation, no response. So call her after another 2 days. Even then, if there is no response, then increase the dose by 37.5 to 75. How do I decide? If the total antral follicle count is too high, more than 20, then add only 37.5. If the total antral follicle count is between 14 and 20, then add 50 international units. And if the total antral follicle count is less than 14, you can add 75. If the total score is more than 20, 20 to 22, which means it is a PCO patient. That means you don't want to go for a hyperstimulation. So you say on day 5, but you don't increase the dose. You call them after another 5 days with the same dose. And when they come after, on the day 10 of stimulation, when I say stimulation, it is gonadotrophin stimulation. So when you say them on the day 10 of stimulation or day 10 of gonadotrophin, even then there is no response. That is when you would add only 37.5. But if the score is more than 22, severe PCO patient, typical chronic low dose protocol is what you are going to follow. See on day 5, no response, continue same dose. See on day 10, no response, continue same dose. See on day 14, and even then there is no response, only then add 37.5. And if your stromal flow is correctly calculated, you will not need to increase the dose for the second time for sure. Whereas if it is an IVF cycle, we cannot continue stimulation so long. We know we have a limit of 10 to 12 days of ovarian induction. So you are going to do there, you are always going to do a scan on day 2 and you start stimulation, and if on day 5 of stimulation when you call the patient, if you see that there is no response, again no follicular growth, no endometrial growth, that is when you will increase the dose depending on the baseline score on the same day. If the patient's score was less than 10, add 75 RLH to 75 and 75 RFSH, or add 150 HMG. If the score is between 10 and 20, normal reserve, normal responding, then you will add only 75 RFSH. And if the score is more than 20, PCO patient, add only 37.5. And then call the patient after 2 or 3 days according to the size of the follicle. So that would be your IVF stimulation protocol. Now, if I am talking of only RFSH, why did I here ask you to add LH? It is not a random decision, it is a scientific reason for that. If I am talking of patients who have low score, which means they have low flow and they have less size. If they have low flow, that means it is important to understand that the ovarian stromal flow is a function of VEGF and it is a function of LH. It is LH which leads to neoangiogenesis, so new blood vessel formation, and it is LH which is responsible for low resistance flow because of catecholaminergic stimulation and leukocyte cytokine activation. So if we just remember that it is LH which is responsible for the stromal flow, if I have a less score, that means the flow is also less, and therefore these patients are going to respond poorly. But not only that they are going to respond poorly, it indirectly indicates that the LH is either has a low bioactivity, or it has a receptor polymorphism and it is not perceived, or the LH level is low. So it's only in this group of patients that you need to do an LH supplementation. As far as IUI is concerned, as I told you in the morning, most of the times LH supplementation is not required, because no matter how poor reserve a patient is, she still has some amount of LH, and we are not going to downregulate them, and that LH is sufficient for the follicular maturity. But in IVF cycles, the patients who have low LH, you are going to downregulate them, that LH is further going to go down, will almost reach nil levels, and therefore in these patients you need to do an LH supplementation. The only one thing, and this is the same as also been described in the Poseidon criteria. If you see Poseidon criteria 1 and 2, the patients who have low reserve but still respond poorly, these are the patients who require LH stimulation. In the IUI cycles, I forgot to tell you what I was telling. I did tell you that in the patients who have follicles up to 14-15 millimeters they reach, but they still don't show flow, these are the patients who would require LH supplementation. There's only one thing that needs to be remembered, and that is, if you're on the day when you're going to start gonadotropins, and if all the follicles are smaller than 7 millimeters, follicles, they are androgen dependent up to 6 or 7 millimeters. Beyond that, they become FSH sensitive. Beyond that, 9 or 10 millimeters, they become FSH dependent. So as long as the follicles are all small than 7 millimeters, there are no FSH receptors. Even if you give FSH, it will increase the blood level, but it will not work on the follicles. On the other hand, it is androgen which not only recruits follicles from pre-antral to antral, but it also sensitizes the follicles to FSH. So if you start FSH that early, not only you will consume more FSH, but you will also lead to multifollicular development, because the blood level is increasing and more follicles are getting sensitized. So it will lead to multifollicular development. So if all the follicles are lesser than 7 millimeter, On the day of your start of gonadotrophin, in your IUI cycles, you can delay the stimulation for a day or two, which will ultimately result in a mono or a bifollicular development. Yes? So that is for the baseline scan. Now what I know, your questions is, I am doing a baseline scan, and if I am seeing already a cystic lesion there is a cystic lesion which may be anechoic or which may have internal echoes. What is the significance? If you have an anechoic cystic lesion which is less than 12-13 millimeters, which means it is mostly an early recruitment of the follicle, put on a Doppler. If it shows flows, because we know as soon as the dominance is achieved, the flow will be there. So if it shows flows, it is an early recruitment of the follicle. If it is an early recruitment of the follicle and it is for an IUI cycle, you should ideally not cancel any cycle, because if it says early recruitment of the follicle, that growth of the follicle beyond 10 millimeter is not possible without rising FSH. And if that follicle has grown, that means the basal FSH is high. If the basal FSH is high, the patient is aging. Ideally, any cycle should not be cancelled. You can start stimulation for that patient, start with gonadotrophins if you want to right away, but start with one dose lower. Say for example, my baseline score says this patient requires 75, I will start with 50 or 37.5. So that the maturation instead of 4 days will take 6 days, that should be sufficient. Instead, if I am seeing this cystic lesion which is more than 25 millimeters, which is more than 25 millimeters, or say more than 15 millimeters. If it is more than 25, I will think in terms of follicular cyst. And if it is still within the range of 15 to 25, I will think of residual active follicle of the previous cycle, residual follicle of the previous cycle. Why would there be a residual follicle of the previous cycle? Because in the previous cycle, when the surge came, there were 2 or 3 follicles which were still in the growing phase, mid-size. So they remain as growing follicles even in the next cycle sometimes. They don't regress with the menstruation, they may remain there. Whatever is the cystic lesion, put on the blood flow. Put on the Doppler. If you see blood flows, only then it is hormonally active. So this regressing follicle will show scanty flow, and if it is there, it is high resistance. Even if it is a follicular cyst, it will show scanty flow and it is high resistance. But if it shows no flow at all, most of the times it is a simple cyst. Of course, you have to, if it is a septated lesion, you think of serous cyst, adenoma and so on, but generally, this is what you commonly find on your fertility scans or on your monitoring cycles. If you see that there is a cystic lesion with hyperechoic walls and internal, low-level internal echogenicities, it is a residual LUF of the previous cycle, put on a Doppler, scanty high resistance flow, hormonally not active, not to bother about. If you see that it appears like a corpus luteum or a hemorrhagic cyst, so that is when you put on the Doppler. If you see that, so there are fishnet pattern, honeycomb pattern, fibrin strands inside, put on a Doppler, and if you still see a nice ring of color with a low resistance flow, that tells you that this is a residual active corpus luteum of the previous cycle. Confirm that the endometrium is thickened and hyperechoic. Confirm with the patient that she is not throwing enough this cycle. That tells you this is a residual active corpus luteum. It is in this patient, if you have done a scan on day 2, repeat a scan on day 5. And on day 5 also, if it shows that changes, or on the day when you are going to start gonadotrophin, if it still shows the same, that's when you omit the cycle. But if the flow starts decreasing, that means the corpus luteum is regressing and you can go ahead with the stimulation. If this lesion is showing high resistance flow, that means it is a regressing corpus luteum. Again, the progesterone that it is producing is not going to be adequately bioactive, is not going to come in the way of your stimulation. Forget about it and go ahead with the next cycle. And even if it is a hemorrhagic cyst. So now if I say hemorrhagic cyst, remember hemorrhagic cyst is a term only used for those lesions where the corpus luteum has stopped functioning, so has no flow, but still anatomically has not regressed. That means it's hormonally not active, it's not going to come in your stimulation, don't bother about it, go ahead with your stimulation. That means it is only one lesion which you have to remember, and residual active corpus luteum, and it's only in this lesion that you cancel the cycle. Rest all the cycles you can go ahead. If I talked about the follicle which is early recruited, and if it is an IVF cycle, remember that if you have multiple follicles following in the cohort, you can ignore that follicle and wait for the rest. So endometrial pathologies on ultrasound and hysteroscopy. Endometrial pathologies can be what? It can be inflammatory, it can be post-traumatic like synecdoche, or it may be neoplastic like polyps, hyperplasia, malignancy, so on. What we will do today is we will restrict ourselves to the endometrial lesions that we commonly see in the infertile patients. Since we have been discussing infertility since morning, we will mention a little bit about malignancy, but we will not do malignancy in detail. So endometritis, if you say, it may be acute or chronic, and it may be of an obstetric origin, or it can be of a gynec origin. The incidence you all know, but we know that most of the times when there is endometritis as a result of obstetric origin, there is a possibility of either products of conception there left, or there may be some foreign bodies in there, or there may be infection because of improper labor practices. Because of gynec origin, it is because most of the times associated with PIDs, the pelvic infectious diseases. It may be because of neoplasms of the cervix, it may be sometimes because of IUCDs, or maybe because of radiation therapy, because of atrophy and so on. But then, whatever the cause, let us see the findings, because cause we can find out from the history, but the findings we have to see on ultrasound. If we say it is acute endometritis, remember acute inflammation anywhere in the body will lead to two things: one, edema, and two, hyperemia. The same thing will happen with the endometrium also. The endometrium becomes thickened, but the thickened endometrium is normal and natural in the proliferative phase, in the pre-ovulatory phase, and in the secretory phase. Therefore, the acute endometritis can only be diagnosed during the early proliferative phase, when generally you expect a thin endometrium. So you are expecting a thin endometrium, you are expecting an avascular endometrium, but in spite of that, you see that the endometrium is thickened. The endometrium is thickened in absence of either an early recruitment of the follicle or a residual corpus luteum, and you also see that the junctional zone is irregular. This is what tells you it is acute endometritis. But as we know, acute endometritis is often an association with the PID, and therefore, oh yes, if it is of an obstetric origin, it is possibility sometimes it is because of anaerobic infection, and that is when you may see air in the endometrial cavity. Thank you very much, and sorry for the trouble. So you may see sometimes air in the endometrium, and that appears as hyperechoic endometrium, hyperechogenic shadows in the endometrium. If I say that it is often associated with PID, how do we know? Do we have other signs of PID? Yes, you may have blood or pus in the endometrial cavity. You may have free fluid in the pouch of Douglas or surrounding the adnexa, which may show tissue strands, which is because of pus. And then you may also have pain on probe pressure. The cause for the fluid in the endometrial cavity that we saw here must always be sorted out by asking the detailed history and doing the systemic examination of the patient, which would tell you what is the cause of infection. When you see free fluid in the pouch of Douglas or surrounding adnexa in PID, along with the free fluid, you may also have, the patient may also have acute salpingitis. And as I described in the morning, if there is acute salpingitis, there is going to be a thickened tube, And you can beautifully see here how the thickened tube looks like, and it also shows pruning of the fimbria. The fimbria, which otherwise looks beautiful like fingers, they actually appear like shortened fingers. This is called pruning of the fimbria. And along with that, if you put on a Doppler, you will also see vascularity, which is low resistance and is running across the width of the adnexa. Sometimes it may have progressed beyond meningitis, and there would also be a hydrosalpinx, and because it is an acute inflammatory hydrosalpinx, therefore it will also have thick walls, as you can see in that clip. There would be also thick walls. You can see a clearly thick mucosa there, which appears like tiny solid projections. And moreover, it is these tubes which are still easily, distensible. And because they are distensible, therefore, one end of it may appear much more wider than the other end. Moreover, as I was showing you in the morning, which I was not able to, and I didn't want to spend time, you are also seeing the waist sign of the hydrosalpinx, and those are the signs which tell me, yes, this is acute inflammation of the tube. So we have seen free fluid, we have seen acute endometritis, we have seen free fluid in the pelvis. I have talked to you about acute oophorytis also in the morning. Progressing beyond that may result into a TO mass, and that would be either in the form of hydrosalpinx with a waist sign or incomplete septum. You may also sometimes see a large mass where you cannot differentiate between the margins of the tube and the ovaries, but it appears like a complex mass. And these are all the signs of acute inflammation. If it is an obstetric origin found by the history, you must always in detail see the uterus, which is still involuting. Therefore, the myometrium appears bulky and absolutely heterogeneous, and you should see for any presence of foreign bodies inside the uterus, as well as you must also look for formation of sinuses. You can see here, apart from the heterogeneous endometrium, you also see a gap communicating outside. You are seeing it in here also. So find out presence of sinuses or foreign bodies in the endometrium. Those are all the signs of acute endometritis with or without PID. Coming to chronic endometritis, thin endometrium with altered junctional zone, which may be irregular most of the times. There may be hyperechoic flex in the endometrium. There may be hyperechoic flex in the endomyojunction. Sometimes you may also see hyperechoic flex in the myometrium. If you put on a Doppler, there will be scanty vascularity not only in the endometrium but also in the subendometrium. And apart from that, there may also be sometimes calcified flex. Whenever you see calcified flex, it is important to identify how thick they are. That is where 3D can be useful, but 3D is not always required. You can just put some saline inside, and if you put saline inside, you can beautifully see where exactly the calcification exists. If we are seeing chronic endometritis, we must always keep into consideration the possibility of tuberculosis, and if there are a few signs which are more commonly seen in tuberculosis, but they are not specific for tuberculosis. So if you find them and there are other supportive signs, you can say, yes, this is possibility of tuberculosis, but tuberculosis, you usually have to confirm it on a histopatho of the local hysteroscopically found lesion. The signs that are more commonly seen with tuberculosis are: 1, thin endometrium, irregular junctional zone. You may find fluid in the endometrial cavity with micropolyposis, as you can see. If you have micropolyposis but you still do not have fluid in the endometrial cavity, the entire central line will look irregular. As I told you earlier also, you may have hyperechoic flex in the junctional zone. Hyperechoic flex may be present in the myometrium and in the endometrium also. And as we were seeing in the morning, see, there is a fluid in the endometrial cavity with hyperechogenicity of the inner line, as we saw in that septate uterus. There may be contracted cavity and there may be scarring in the cavity, which all may be possibly due to tuberculosis. Apart from that, patients with tuberculosis may also show myometrial cysts, which are very common to what you see in adenomyosis. But in adenomyosis, if you put on a Doppler, they will show peripheral flow. When I say myometrial cyst, it is an anechoic lesion with peripheral hyperechoic margin. So if it is adenomyotic myometrial cyst, you will have peripheral vascularity, but if it is tuberculosis, you will not have any peripheral vascularity. And this is a very important differentiating sign, because both adenomyosis as well as tuberculosis will show you thin endometrium, will show you irregular junctional zone, will show you myometrial cyst. But it is only the vascularity around the myometrial cyst which will tell you it is adenomyosis, and no vascularity surrounding myometrial cyst which will tell you it is tuberculosis. Synecdoche, if we talk about, synecdoche are best diagnosed on, even if you are doing only 2D, they are best diagnosed on the saline infusion sonohysterography, where you just need to put a Follis catheter, which is 6 or 8 French. You can attach it with a connector so that a syringe can be attached with it, and you just put the balloon of the Follis is fixed in the cervical canal, not above the internal os, and then you would have to distend the endometrial cavity only with about 3 to 4 ml of normal saline. And depending on the tightness of the synecdoche, you may see some fluid. You are seeing fluid here also. See, you are seeing, in this case, you are seeing fluid only in the lower half of the endometrial cavity. You are not seeing any fluid in the upper half, which tells you there is a complete synecdoche here. Here it is a synecdoche in the lower half of the body. Whenever, in fact, I would tell you, if you are seeing, this is another case here, where as in the morning I was telling you, if there are fluid loculi, this is a surest sign there are synecdoche. If you remember, somebody was there in the demo when we were doing. So these are all the signs which will tell you there are synecdoche. This is not Nick. This is in the fundus. Oh, that is there. That it is just a small cavity. It's not a niche. It's not a niche. It is just like morning. It is just a small fluid collection. It is not a niche. I told you, when it is a niche, it has to be triangular. It has to have the base on the endometrium, and it has to have the apex towards the serosa. This is round. This is not a niche. And it is the base is also not on the endometrium. So this is more of, this is more of just a weakness. And so first one is the upper one. I would stop here and show you, because since you have a question. In fact, let me see it very more closely. Probably both of these are Nabateans. Both of these are Nabateans, and they are not niche or anything. So, moreover, you may also, so it is sonohysto. Again, one more case here. See, you're putting in saline and you see your catheter is being withdrawn, and you can see the entire cavity is open. But even if you see here, the synecdoche are in the lower half. Look at that here, right? So this is a very effective way. There are again synecdoche seen here on sonohysto, seen here on hysteroscopy. So synecdoche is very, very beautifully, not only synecdoche, even polyps, they are very beautifully seen on the sonohysto, and therefore you only need to do hysteroscopy for the treatment purpose. The diagnosis can be done only based on ultrasound. Apart from the signs of tuberculosis that I showed here, because the last sign was synechy, I have continued and finished this discussion on synechy, but tuberculosis, when it spreads beyond the endometrium and the uterus, you may also see free fluid collection, which is associated with septations, and the septations may have hyperechoic nodules. There may be a lattice-like pattern with low-level echogenicities. There may be low-level echogenicities in the fluid with floating cysts. Whenever you see floating cysts like that, that is when you should always rotate the probe and find out its relation with the fimbria, if there are any. If there is a relationship, if they are in the close vicinity with the fimbria, these are not floating cysts, these are fimbrial cysts, but if you don't find any fimbria around, these are floating cysts and they may be a indication of tuberculosis. So that is what is all about endometritis. Going to polyps, solid lesion arising from the endometrium, intact endometrium-ammetrial junction. The prevalence is very high. You cannot exactly predict the prevalence, because just for the reason that most of them are asymptomatic, and the polyps may be single or multiple. Even if they are multiple, every single polyp shows a single feeding vessel, and it is a single feeding vessel which is diagnostic of a polyp. As I told you in the morning, when there are small and subtle polyps, there will be only irregularity of the central line, and when you see that irregularity of the central line and you see it closely, that is when you identify, yes, there is a subtle polyp there and a subtle polyp there. So looking and observing the central line and its curvature is very important. Sometimes the polyps may be larger and they may fill up the entire endometrial cavity. You are seeing here also, it doesn't actually fill up the entire endometrial cavity but fills up the fundus. Whenever you have doubt, always put on fluid in the endometrial cavity and you can beautifully see the polyps clearly separate from the rest of the endometrium, and that is diagnostic. If you compare the ultrasound images with the hysteroscopy, they are absolutely correlating, and that is what is the beauty of ultrasound. I would tell you that since maybe more than about 10-12 years, we have stopped doing any diagnostic hysteroscopies. All the diagnosis can be done only on ultrasound. Hysteroscopy is only done for the therapeutic purpose. Generally, we know that the polyps have a single feeder vessel and they are generally appear homogeneously echogenic. But whenever you see that the polyp appears mildly heterogeneous in echogenicity, as you are seeing here, or you would also see that the vessels inside this branch, that means that it is either adenomyomatous polyp or it is an atypia. When the resistance in these vessels is less than 0.45, that is when atypia is suspected, but the resistance is in the range of 0.5 to 0.6, that is when adenomyomatous polyp is suspected. Apart from that, whenever there is polyp, you may also have to differentiate it from the type O fibroid, we know, which is intraendometrial fibroids. And the important differentiating signs, of course, are single feeder vessel and the ring of vascularity. So single feeder vessel in polyp and a ring of vascularity in the fibroid. But a very important 2D sign is that polyp, since it is echogenic, it is better seen on the proliferative phase where it is a multilayered endometrium, whereas fibroid, which is usually hypoechoic to the myometrium, it is almost the same echogenicity as the echogenicity between the lines in the endometrium, therefore may be missed in the proliferative phase, but because they are hypoechoic, they are best seen in the secretory phase. And the third important differentiation is that when there is a polyp, the endomyojunction is absolutely intact, whereas when it is an intraendometrial fibroid, that is when the entire junctional zone will be infolded. So those are the differentiating points between the fibroid, between the type O fibroid and a polyp. The endometrial fibroids, even if it is not type O, is type 1 or type 2, that is when it needs to be evaluated as to how much of the endometrium is involved in it, and it is for that 3D ultrasound is of a great help. The 3D ultrasound can actually show you exactly as to how much of the endometrium is involved. And again, look at the harmony, look at the synchrony between the laparoscopic findings and the ultrasound findings. Here there is a fibroid which is say type 1. This is a fibroid here which is again probably type 1. This is a muscular fibroid. This is again type O fibroid. So you will always see this same images on the hysteroscopy and the 3D ultrasound with sonohystro or even without sonohystro. So that is something very, very useful whenever you have fibroids. Let us now move to another lesion. As I told you, if there is a large polyp, it may cause thickening of the entire endometrium, or sometimes it also happens that the polyp is not very large but there are multiple polyps. Because of that, they fill up the entire endometrial cavity, and therefore they may appear similar to the hyperplasia. It looks like a completely thickened endometrium. You may put on a Doppler, and it may show, if it is a single polyp, it may show a single feeder vessel, but sometimes if there are multiple polyps which are leading to thickened endometrium, it will appear very similar to hyperplasia, because the hyperplasia also shows regular distribution of the blood vessels, as you can see here. In these cases, again, sonohystro can be useful, but if you have confirmed that it is a hyperplasia also can be two types. We know that the hyperplastic endometrial tissue consists of stroma and the glandular tissue. If the glandular tissue is predominant, that is when you would see multiple anechoic areas of various sizes, and the vascularity is scanty. Whereas if you are seeing a stromal predominance, that is when the endometrium appears more solid, the tiny anechoic areas are there, but they are scanty and they are very small and similar in size, and moreover, it will show increased vascularity. It is often difficult to differentiate hyperplasia and the malignancy, endometrial malignancy in situ, because as long as it is in situ, it will show intact junctional zone, which is a characteristic feature of hyperplasia also. Whereas if it is malignancy, that is when the vessels will, the first thing is the junctional zone will be irregular, the endometrial thickness is more, the endometrial echogenicity is heterogeneous. If you put on a Doppler, it will show heterogeneous distribution of the blood vessels. The single blood vessel will all have various diameters, so the same vessel will be thickened somewhere, will be narrower somewhere. The vascularity extends into the myometrium, and these are all the signs which would tell you it is probably endometrial malignancy. Coming to fibroid polyps. Fibroid polyps is a term very loosely used for any large polyp, but remember, when we say fibroid polyp, it has to have a myometrial component. So it actually arises from the myometrium and it protrudes inside the endometrium. It has vascularity, which is a single feeder-like vascularity with branching inside, but that origin of that vessel is not only from the spiral vessels, it is from deep from the myometrium, and that is the true fibroid polyp. There may be scars, there may be weakened scars, and anything like this. So if you can now differentiate what you saw earlier, so that is what is a niche. It is triangular, based on the endometrium, and it is the apex is towards the serosa. We know that when the scars are large, you measure the distance from the tip of this triangle to the, from the tip of this triangle to the serosa. If the distance is less than 3 millimeters according to some studies, less than 5 millimeters according to others, it is considered to be a weak scar which will not hold the pregnancy or will not allow a normal labor. It is in this cases that a repair may be suggested, but not all patients will agree with it. But sometimes the scar niches are extending right up to the serosa. sometimes we have also seen that this niches may be communicating with the peritoneal cavity that will lead to continuous fluid leaking inside the endometrial cavity. In these patients, when you are doing monitoring, you will often see fluid in the endometrial cavity and will not allow the endometrium to grow well. It is all these cases where you would require to repair the niche, and after that the pregnancy is quite easy. Sometimes you may find absolutely atypical scars in the endometrium, and this is quite common when the endometrial, subendometrial fibroids have been removed, which is not very common in polyps. Subendometrial fibroids are removed, and these scars are very difficult to treat and very difficult to give a pregnancy in these patients. IUCDs. IUCDs, if we talk about, yes, generally we used to once upon a time measure the distances. If we are using only 2D, we used to measure the distance from the tip of this to the serosa, and we used to measure the thickness of the myometrium, and we used to calculate as to whether the IUCD appears in place or it is displaced. But now with 3Ds, you can see the IUCD so very clearly that whether it is normal in position or it is displaced can be beautifully diagnosed only on 3D ultrasound. You can also find out whether it is invading into the myometrium, whether it is fixed there, whatever. So that is one more thing. So ultrasound is a modality of choice. Periovulatory is the phase where you assess it for all the endometrial lesions. Abnormal early pregnancy, I will go very fast through it. Let us only discuss about abnormal early pregnancy more in detail. We know that when we are talking about early pregnancy, we are talking about a pregnancy of 4 weeks till about 11 weeks, 10 to 11 weeks. And yes, it is right that you are not doing 3D, but this is not to fascinate you. It is truly to explain you that how much can a 3D do. How much can a 3D do? It can show you the details of the anatomy so very beautifully that you can never ever make a mistake in diagnosis. We know that pregnancy starts with the implantation of embryo, which occurs about 4 to 7 days after the ovulation, and the earliest pregnancy prediction can be done as early as in the mid-luteal phase. In the mid-luteal phase, when I told you that the corpus luteal RI has to be less than 0.5, this is a very important prerequisite for the pregnancy, because unless the corpus luteum is supportive, the pregnancy is not going to survive. Apart from that, yes, you all remember that in the luteal phase we saw the endometrium, and the endometrial flow should be present, and that should also be a low resistance flow. But we also need to remember that when we measure the flow here, if we look at the PSV also, and the PSV is more than 5 centimeters per second, this is one of the positive predictors of pregnancy in the mid-luteal phase. Not only that, in the mid-luteal phase or in the late luteal phase, if you see that the endometrial cavity, the endometrium shows asymmetrical thickening of the lips, where the thickened lip also appears hyperechoic. And if you put on a Doppler, if you see that the vessels are converging towards one single point, these are the signs which tell you that this is probably an early intrauterine pregnancy. This sign is called color comet sign of early pregnancy. But we know that this only predicts pregnancy. The confirmation of the pregnancy is done only after the missed periods with either the positive urine pregnancy test or a positive beta-HCG in the blood. And positive beta-HCG is concerned as a specific sign for pregnancy. But we know that though it is a sign of a positive pregnancy, it may be seen even in the ectopic pregnancies. It may be seen positive in vesicular moles. It may be positive in patients with dysgerminoma, choriocarcinoma, extrauterine pregnancy, and molar pregnancy also. That means whenever you see that the beta-HCG levels are above 1500 milli-international units per ml, and still you are not seeing an intrauterine gestational sac on your transvaginal scan, that is when all these things must be always considered. If at all, those are the things which you consider if you don't see a sac. If you see a sac, intrauterine sac, if you have confirmed on the ultrasound, You need to check the viability and the prognosis of the pregnancy. You need to check the embryo for the structural abnormalities and the chromosomal abnormalities. The assessment for the chromosomal abnormalities goes back towards the pregnancy of about 12 weeks and nuchal scan, etc., which is what we are not going to discuss today, since we are discussing only the early pregnancy. But apart from the viability and the structural abnormalities, it is ultrasound which also helps you to find out if there are any intrauterine hematomas, if there are any abnormal locations of the pregnancy inside or outside the uterus, and also if there are any trophoblastic tumors. Starting with the viability of the pregnancy, normal growth rate of the gestational sac, appearance of the yolk sac, appearance of the growth, appearance and growth of the fetal pole, appearance of the cardiac activity. These all things have normal timelines and the growth rates, and they have to follow that to tell you that the pregnancy prognosis is good. Going very, very quickly, 4 weeks you will see a gestational sac 2 to 3 millimeters with anechoic central part and hyperechoic outer margin. It is always seen eccentric in the cavity, not in the center. It aborts the endometrial cavity only after, completely aborts only after 8 weeks. Till then you may see some endometrial cavity still, as you are seeing here also. And if you switch on the Doppler, you will see a lot of peri-sac blood flow, which is a positive sign for a live pregnancy most of the times, but not always. 5 weeks you will start seeing the yolk sac inside, and you are also seeing a tiny fetal pole at the end of the 5 weeks, 5.5, 5.6 weeks. And it is, even when it is just 1 or 2 millimeters in size, it is only by the cardiac activity that you see inside you diagnose this is a fetal pole. This keeps on enlarging, becomes elongated in the 6th week. In the 6th week, you can also clearly identify the cephalic pole and the caudal pole. Beyond getting straightened, it then gets curved, as you can see here, and you are also seeing the neural tube development. That tiny limb birds may sometimes be seen as early as end of the 6 weeks, but mostly it appears at the 7 weeks. At 7 weeks, you will also see the rhombencephalon. You are not going to put on the Doppler, so I am not going to talk of it. And you will, at the end of the 7 weeks, you will definitely see tiny limb birds, which are called hand and foot plates. The amniotic membrane must always be seen by 7 weeks, and by 8 weeks, you should be always able to see the limb buds clearly. It is by 8 weeks that the fetus straightens up a little, and it remains a bit straightened till about end of the 11 weeks, and therefore when we date the pregnancy, we always plan to date it by 8 weeks, between 8 weeks and 11 weeks, and that is probably the most reliable time to date the pregnancy. Moreover, it is by 8 weeks that if there are any twins and they are going to vanish on their own, that will happen by 8 weeks. So 8 weeks is a time, is a scan which is truly an important scan. And if you find everything is normal at 8 weeks, most of the times the pregnancy prognosis is good. You would by the end of 8 weeks, you will definitely see, apart from rhombencephalon, the rest of the other 2 cerebral vesicles also. You can beautifully see it on the 3D here. You are seeing a typical C there, which is a prosen, meson, and the rhombencephalon. If you look at it closely, you will also see the neural tube here. You would see that the limb buds have now developed into 2 segments, the upper and the lower segment. And it is the cephalic pole, which may also, if you see on the coronal section, will show the 4th ventricle too. At 8 weeks, umbilical hernia actually becomes visible only at the end of 8 weeks or 9 weeks, or starting of the 9 weeks. The limb buds now are very clearly seen, and the hands also start developing. The cord insertion is seen, and the entire embryonic circulation is there. 9 weeks, the head makes half of the fetus. The facial details are faintly identified. The fingers, you can see here, the toes are seen. The fingers are formed at the end of the 9 week. The upper limbs, though, grow faster than the lower limbs, and the hernia is always seen at that stage. Not only that, You will see the clear prominence of the coccyx, thus identifying the neck and the coccyx separately. 10 weeks, you will see all the 3 cerebral vesicles. You will also see the cerebellum. You will see the hand and the feet. You will see the falx. The spine ossification starts. So that is all, those all things you can see. You can also see the choroid plexuses. You can also see the choroid plexuses. You will see the stomach, bladder. You would also see the kidneys, and you will also see the renal and the iliac arteries, and the heart has already become 4-chamber. Sorry? Yes, yes. Always. No, I'm not. Who asked me? Somebody asked me. If you want me to, I can include. In that case, we will have to cancel something else, because it's going to be actually too exactly, because it is more of a fetal medicine, and today we are discussing more about the infertility and the gynec scans. So you would also see the umbilical hernia that starts disappearing there, and you would also see the fingers and the toes. If you asked me, it is all transvaginal scan. Yes, let me tell you that with all the new standards nowadays, the entire first trimester assessment has to be done by the transvaginal scan. Not only that, even with the nuchal scan, we do a detailed anatomical scan, and that also we do it with the transvaginal scan. So transvaginal is a very safe way and a very effective way of evaluating the fetus, and you can, at 12 weeks, it is a completely formed fetus. You can see all the anatomical details very beautifully, including the nasal bone and everything, the stomach there. You can also see the details of the spine, the details of the ribs and fingers and everything. And not only that, you can also identify the movements of the probes, movements of the fetus, which are very active, and they are very, very decision, I would say gold movements, in the sense they decide, I am going to touch the nose, I am going to touch the eye, and I am going to touch the chin, and so on. So they are very definite and gold movements that happen. With that normal growth, what are the abnormalities that you can diagnose in the early pregnancy? It can be abnormal prognosis of the pregnancy. It can be abnormal location of the pregnancy. It can be pregnancies with vesicular moles or chorioangiomas. It can be pregnancies with uterine abnormalities, and it can be pregnancies associated with other pelvic abnormalities. Pregnancies associated with other pelvic abnormalities, which may be ureteric stones, which may be appendicitis, which may be many other things, and therefore I have not included them here today in this presentation. The rest of the things we will discuss. Coming to pregnancies with abnormal prognosis, it can be abnormal gestational sac, it can be abnormal yolk sac, it can be small CRL, so the short CRL, it may be late appearances of the cardiac activity, abnormal cardiac rate or rhythm, abnormal amniotic sac bands, or it may be perisac hemorrhage. But before that, before you diagnose abnormal prognosis, or whenever you doubt an abnormal prognosis, that is when looking at the biochemical profile is very important. We know that during the pregnancy, the HCG rises during the first 12 weeks, then it may fall a little, and then it may reach a plateau and may continue or decrease beyond that. We know that the progesterone levels, they keep on rising, the estradiol levels also, they keep on rising. If at all you see that this does not follow a normal pattern, when there is a fall in HCG or fall in progesterone or estrogen before 10 weeks, these are the signs which indicate a bad prognosis, and therefore it is very essential that if we say progesterone is, I would say progesterone is the first sign, fall in progesterone is the first sign which would tell you that the pregnancy is not going to survive, or it's at danger. We know that the progesterone levels can be predicted from the corpus luteal flows, and therefore it is essential that at least till 8 or 9 weeks, every corpus luteal flow must be evaluated. In every pregnancy, corpus luteal flow must be evaluated, and if you find a rising RI in the corpus luteum, this is a sign of a bad prognosis. These are the patients, if they are supported by progesterone, even if it is a natural pregnancy, if they are supported by progesterone, can have a better prognosis. Looking at the other prognostication signs, let us start with the gestational sac. We know that the gestational sac is going to appear at about 4 weeks and 3 to 5 days, when it will be very small. It has a definite normal growth rate of about 1 millimeter a day, at least 1 millimeter a day. Regular thick echogenic wall, which you know, which is because of the double decidual reaction. It must be ideally implanted into the upper half of the endometrial cavity and should be eccentric in location. And remember that even at the beginning of the pregnancy, the decidual thickness should be at least 3 millimeters. When you measure the gestational sac before the appearance of the fetal pole, it is essential that you would always measure it as, or document it as, mean of 3 longest diameters. But once the fetal pole appears, this doesn't have much significance unless it is too large or too small, and therefore you can mention it as a single diameter. It is whenever the gestational sac is irregular, we know that it has a poor prognosis, and the reasons can be either it can be either myoma, uterine contractions, perisac bleed, over-distended bladder, etc. But whenever you find that it is irregular, it is important that you would document the volume of the gestational sac rather than just the diameters. Ideally, it occupies about 1/3 of the uterine cavity at 7 weeks. Looking at abnormal gestational sac, and gestational sac which has a decidual thickness of less than 3 millimeter, it is too large or too small. Again, there is no size cutoff for the same, but it is too small and it is almost opposing on the yolk sac and the fetal pole, or it is too large where you have to find the gestational the yolk sac and the fetal pole in some small corner. These are considered abnormal. When the sac is more than 9 or 10 millimeters and it doesn't show yolk sac normally will be seen when the gestational sac reaches about 5 millimeters. But if you don't see any gestational sac, when you don't see any yolk sac when the gestational sac reaches 9 or 10 millimeters, that is an important sign to tell you there is probably something abnormal. But you don't document it as a failed pregnancy. You just alert yourself and the patient, I feel that the growth is a little slow and we will have to watch it a little more closely. Similarly, the fetal pole normally appears at 15 millimeters, but sometimes it may happen, it may not appear till then. And if that is the case, that is also a sign which would indicate a guarded prognosis. Abnormal gestational sac size is associated with trisomy and triploidy, and the growth rate of the sac, if we said normal is 1 millimeter a day, even if it doesn't grow, if it grows up to 0.7 millimeter a day, it's still fine. But if the growth rate is even lesser than that, that is when it is truly a bad prognosis. Though it is important to remember that the perisac flows always are not different in the normal and abnormal pregnancy, and therefore that should not be taken as the only parameter to tell you that it is a good or a bad prognosis of pregnancy. Again, quickly, the large gestational sac, the small gestational sac, and that is the perisac hematoma. You have to, when you see the perisac hematoma, every time you don't have to get disturbed. Many times it is only the unabated endometrial cavity, and the unabated endometrial cavity may also appear like a perisac hematoma. But when there is an unabated cavity, that is when, remember, you will see its continuity with the rest of the endometrial cavity. You may also trace it towards the cervical canal. With hematoma, again, there may or may not be bleeding. If it is bleeding, we call it a threatened abortion. If it is no bleeding, it is just an incidental finding. There may be a perisac hematoma. Perisac hematoma, it is not the size, it is location which is more important. Yes. Please, a little loud. Yes. The diagnosis is perisac bleed, but it is not a threatened abortion. No, we have to wait and watch. It may not grow at all, or it may be resulting into any of the chromosomal abnormalities. But we have to wait and watch, only then we can say what happens to it. But it only says prognosis is poor. So perisac bleed, when you see it, it is towards the fundus, or it is larger than covering more than 1/3 of the gestational sac. That is when it is usually considered to have a poor prognosis, and moreover when it is under the chorion frondosum rather than under the chorion leaf. So that is when it is more risky, that is when it has a bad prognosis. But the hematomas which are smaller than covering 1/3 of the gestational sac, more towards the cervix rather than towards the fundus, and they also have they are also under the chorionic leaf, that's when they are not of much harm to the pregnancy. But I said not of much harm, I didn't say no harm. So it is very important that you would always counsel the patient with a proper safeguard. Even when you find uterine fibroids, or when you find uterine adenomyosis, even these lesions also, when they are under the chorion frondosum, they are risky. When they are on the chorion leaf side, they do not have much significance, especially as we have seen today also in the morning, when the adenomyosis is too large. Having a pregnancy is not a problem if the endometrium is growing, but it is the second trimester abortions which is a major complication with adenomyosis. Same for the large fibroids also, but the small fibroids may not usually come in the way of growth of the pregnancy. Yolk sac, as we know, is the first visible embryonic structure. Stalk of the yolk sac can be followed to the embryonic abdomen as the vitelline duct. You can see the entire vitelline duct here. This is not an umbilical cord, this is an amniotic membrane here. This is amniotic membrane. Yolk sac usually, as we know, should appear 5-6 millimeter size, so 7 to 8 days after the visualization of the sac. Growth rate of the yolk sac is 0.1 millimeter a day, maximum 6 millimeters. Minimum should be at least 2 millimeters. But if the yolk sac is thick-walled, it is solid-looking, it is irregular, it is too small, that means lesser than 2 millimeters or larger than 2 millimeters, are all signs of abnormal. Too small yolk sac tells you there is not enough nutrition for the fetus, for the growing embryo. Too large yolk sac tells you the fetus is not thriving, and therefore the yolk sac is large. Degenerative changes in the yolk sac with the lack of translucency, that means starts becoming solid, and abundant calcification actually indicates a long-term fetal demise. Sometimes you may find double yolk sac. Double yolk sac, probably, yes, it does say, literature does say it may be morphological differentiation of a delayed disappearance of the physiological midgut herniation or an early abdominal wall defect, but most of the times it is overdiagnosed. Why do I say overdiagnosed is? At times it happens that the fetus has grown to about 6 weeks or so, 6 weeks plus, so the amniotic membrane starts developing, but the growth of the fetus stops there. Because the growth of the fetus stops there, therefore the amniotic cavity remains, which appears just by the side of the yolk sac. Therefore it appears like a double yolk sac, but actually it is not a double yolk sac. If it is truly a double yolk sac, it has to be 2 fetuses, and that would result into a monochorion. The CRL, the fetal pole, appears by about 5.5 to 6 weeks, located adjacent to the yolk sac. We have seen the complete development of the fetal pole. But if you, as I told you, if you see a gestational sac of more than 15 millimeter and you see no yolk sac, that is when it is a problem. It is very important for me to tell you here that whenever we are talking about the abnormal prognosis of the pregnancy, you should not depend on the days of days after the last menstrual period, or don't depend on the weeks. You should always follow the size of the gestational sac. That is important in the early pregnancy, because not in all cases the cycles may be regular, and not in all cases the pregnancy might have occurred at the same time, the 14th day or 17th day. The crown rump length, favorable, it should always be measured in the sagittal plane. So if you can identify the fetal parts, not this early, if you can identify the fetal parts, you should always measure it only in the mid sagittal plane. And the fetal pole also normally grows at a rate of 1 millimeter a day. A slower growth may indicate a bad prognosis naturally. If you see a fetus of an embryonic pole of at least 5 millimeters but no cardiac activity, that is also a failed pregnancy. Yes, it is true that normally there is a difference. I mean, if there is a difference in the CRL of up to 5 days, that is when it is still considered normal and you don't change the dates. But when the difference is more than 7 millimeters, that is a higher risk of chromosomal abnormalities. Though it is also true that it is trisomy 21 and 13 which may it may not be much affected, but for trisomy 18 it is a more reliable parameter. But whenever you find a short CRL, apart from the chromosomal and apart from failing growth of the fetus, also think of spinal canal abnormalities. In early major spinal canal defects, it is possible that the lower part of the spine is not developed, and for that reason the CRL may appear very, very short. That is when you are seeing the neural tube and you will see sudden abruption of the neural tube, which is a sign which tells you there is probably a short CRL because of major spinal defects, and that can be seen as early as in the end of the first trimester. Heart rate, we know that the heart rate starts as very feeble pulsations. At the end of 5th week it is like 100 per minute, end of 6th week 105 to 130, 9 weeks 160 to 170, and then settles at between 120 and 160. If the heart rate is too high, more than 200 per minute, you should think in terms of either cardiac abnormalities, but more commonly possibly trisomy 21, 13 or monosomy X, and severe bradycardia less than 100 even beyond 7 weeks would tell you possibility of triplody or trisomy 18. Amniotic sac, which usually we ignore to see, but it must be seen, should be present at all times after end of 6 weeks. And if it becomes too hyperechoic, if it becomes thickened, this is a sign of abnormality. This is a sign of a bad prognosis. Too large or a too small amniotic sac, don't report it as an oligohydramnios at that stage, but do mention it is large or small, and that is important. What are the signs of failing pregnancy? A gestational sac which is growing at less than 4 millimeter a week, abnormal morphology of the yolk sac, large or small yolk sac, no growth or slow growth of the embryonic pole, bradycardia, and decreasing corpus luteal flow before 9 weeks. But these are the signs which tell you pregnancy is at risk. It looks like failing. It is not yet failed. Okay. But if you want to report this is surely a failed pregnancy, that is when you have to follow the guidelines. Yes, it is true that fetus normally, the embryonic pole normally should appear when the gestational sac is 15 millimeters. Normally appears at 10, you may wait till 15, but you do not report it as it will not appear if until you don't see a gestational you don't see a fetal pole when the gestational sac has reached 25 millimeters, or you are not seeing a yolk sac when the gestational sac has reached 20 millimeters. Why these guidelines? Because once you report that it is not going to grow, that means it should not grow. It should not happen that you have told the patient the pregnancy is failed, this pregnancy is not going to grow, and in some rare 1% or 0.1% of cases, the patient will come back with a 6 months of pregnancy. So that is why the guidelines are a bit strict and they are too wide. If the CRL, yes, it is true that if the gestational sac is not 25, it is 25 millimeters and you're not seeing the fetal pole, but when is a failing pregnancy, it would often happen that the gestational sac will grow at a lower pace, and therefore it is very difficult for it to reach 25 millimeters, and therefore if the gestational sac is not growing, is growing at half the rate of normal, or it is not growing, when you do 2 scans at an interval of 7 days, this is also an indication which allows you to tell the patient this pregnancy is a failed pregnancy, it is not going to grow. So, and similarly, when the embryonic pole, if it is not increasing absence of the fetal pole in the gestational sac, and the sac is not increasing by 75% over a period of week. These are all the signs which tell you it is a fail. I mean, these are the signs which would tell you, which tell you, these are the guidelines. You can say it is a failed pregnancy. Blighted ovum. Blighted ovum, it is an embryonic pregnancy where you are not seeing even the yolk sac. If the yolk sac has appeared and has disappeared, it is not a blighted ovum. That is a missed abortion. But if you are seeing no yolk sac at all, even when the gestational sac has grown beyond 10 millimeters, that is when you start suspecting it is a blighted ovum. If it does not grow so if the volume of the yolk sac is less than 2.5 ml and is not increasing in size by at least 75% over a period of week, just like as earlier, and it doesn't have a yolk sac also, that's when you would say yes, it is a blighted ovum. Missed miscarriage or missed abortion, embryo without cardiac activity, no change in the intervillous blood flow is seen then. It is same as in the normal pregnancy. On the contrary, it is a low resistance flow. Why? Because the normal venous flow is a low resistance flow, whereas the fetal flow is a high resistance flow. Actually, when there is a fetus, there is actually a break on the blood flow because it passes through a higher resistance, and therefore the blood flow in the perisac blood flow is controlled. But if there is no fetus, it is a continuous low resistance blood flow, and therefore it is in this case that you would see nearly normal blood flows or even lower resistance. We have talked about this already, but still vaginal bleeding, if there is there, it may be a threatened abortion, it may be a complete or incomplete abortion. Threatened abortion, we know the fetal gestational sac is still there, and you may or may not see perisac bleeding. Not always. In every case where you have vaginal bleeding, you will see perisac bleeding also. In that case, so perisac bleed is different, threatened abortion is different. These are two absolutely separate things and must be reported separately. Intrauterine hematoma, that is what we discussed already. Now coming to the prognosis of the pregnancy in cases with perisac bleed, I have already told you size, location of the hematoma are the two important things. We have discussed this already, so let's go further. Pregnancy with uterine abnormalities, it may be congenital abnormalities of the uterus or the Mullerian abnormalities in which there may be pregnancies. It may be present in the bicornuate, it may be present in the septate uteri, it may be present in the unicornuate uterus. Remember, any of these things, though yes, it is true that the septate uterus has been blamed a lot for infertility and also for the ectopic pregnancies and all. It is true, it's all true, but that doesn't mean that there is no pregnancy with septate uteri. There are quite a few septate uterus that you also maybe have operated for a cesarean section. So that is quite common, and you may often see this. What is important is when there are any of these congenital or the Mullerian abnormalities and the pregnancy are there, most of these cases correctly because the fetus is there and it is normal, and the placental tissue shows a little more, so a little more thickness and little more anechoic areas. That makes the diagnosis quite difficult. Whereas complete mole, we know that it is usually very clearly thickened endometrium, multiple anechoic areas, bunch of grapes-like appearance, and it as if it develops to a larger size, it may show a lot of vascularity. But it is very important. So in the morning I was asking somebody, chromosomal study has been done or not. Chromosomal pattern for both is different. 90% of the complete hereditary form moles have 46XX diploid chromosomal pattern. All the chromosomes are derived from the single sperm. In 90% or less likely there will be two sperms, meaning the fertilization of a single egg that has lost its chromosomes. So that is what creates a complete molar pregnancy. But when it is an incomplete or a partial mole, there is a normal fetus. So there is 46XY or XX, and then there is a further pair, further entire set of chromosome, so it is more of a triploid chromosomal arrangement. But it is easier if you don't want, if you want to differentiate between chromosome complete and partial mole, where ultrasound is difficult, you can try immunohistochemistry. Immunohistochemistry with P57, it shows absent staining in the complete mole, whereas it does show positive staining in the partial mole and in the hydropic abortus. It is useful, it is cheaper comparatively, and can help distinguishing between complete mole from all its mimics. We already have seen bunch of grace appearance or a snowstorm appearance, and a lot of vascularity, and bilateral or unilateral very active theca lutein cyst are what are the signs of molar pregnancy. Molar pregnancy, when they are complete, that is when it is more likely to go into an invasive nature, as long as you are seeing an intact endomyojunction. As you saw here, the prognosis is quite good. But if you are not seeing a clear endomyojunction, it may be invasive and it may be extending into the myometrium. That is when you would see that it's the hyperechoic tissue which is extending into the myometrium. If you put on a Doppler, both the endometrium and the myometrium shows almost equal vascularity, and the vascular strands are seen extending right up to the myometrium, sometimes up to the serosa. So that is what is diagnostic of the mole. In the patients with complete mole, the possibility of development of choriocarcinoma or invasive mole increases significantly. Partial mole, whereas yes, there is pregnancy, yes, there is fetus. In the very early pregnancy, the fetus appears normal, but in some cases it is the partial mole that weans, and when it weans, that's when the circulation increases significantly. Because of the increased circulation, there's overload on the heart, and that would lead to fetal demise in these cases. So if there is a partial mole initially, you need to follow it very closely. Some of the pregnancies may progress as normal pregnancy, but in some of the other fetuses, because of the cardiac failure, there will be a hydropic fetus. Chorioangiomas, they are often reported as chorionic bumps, hyperechoic ball-like projectile lesions with smooth margins. Put on a Doppler, it will show the same vascularity as the placenta, has a feeder vessel. Small chorionic bumps, they do disappear on their own, but if they grow into the second trimester, they are likely to lead to hyper circulatory states, and therefore will result into a cardiac failure of the fetus. The abnormalities that you can diagnose in the first trimester, the cranium which develops at 9 to 10 weeks, if by 9 weeks if you see that the head is not normal in shape, it shows irregularity, this may be acrania. If there is no brain tissue at all, which occurs a little later, you call it is an anencephaly, but we know that the origin of anencephaly and acrania are different. And you may see a large D-shaped head where the brain tissue is projecting outside. You can see the cranium start developing at 9 weeks, so you will see the bone defect that would be exencephalocele. Anencephaly, as I told you, you may also sometimes have large fontanelle and small crescent-like structures projecting out of that fontanelle, or the defect of the bone which you call meningocele or myelocele, or sometimes encephalocele. These are all diagnosed in the first trimester. Holoprosencephaly, especially when it is alobar, has to be diagnosed in the first trimester. Anencephaly, star-gazing fetus, which is also always diagnosed in the first trimester. Major bone dysplasias, where you have disproportion of the growth of the fetus, the trunk and the limbs, these are also to be diagnosed in the first trimester. Omphilocele, a diagnosis of the first trimester always. And omphilocele can be differentiated from gastrocysis by the attachment of the cord. If the cord attachment is by the side of the lesion, it is gastrocysis. It is on the dome of the lesion, it is omphilocele. Major limb defects, absence of limbs or part of the limbs cannot be missed in the first trimester. That means these are the abnormalities you can be diagnosed in the first trimester, and must be diagnosed in the first trimester for sure. Major cardiac abnormalities should also be like single ventricle and so on, have to be diagnosed in the first trimester. Lastly, assessment of the early pregnancy is of utmost importance. It is the tool of choice is transvaginal scan. Bleeding during the pregnancy.
And also JSB Chittagong branch, all the participants are here. And I think in between the lecture, there are so many question answer, madam answered. And now we have come to the end of the session. Our principal, head of the department, Professor Shahena Akter, will give a memento to our today's speaker. And we are very much grateful, like as it is to Professor Rokeya madam, who always is a source of our inspiration, always guiding us. She is the person who communicated with Dr. Sonal Panchal, a legendary of infertility era, and there are young gynecologists here. All are inspired to have this training, and they are very much happy. Thank you very much, madam. Now I will request Professor Shahena Akter madam to present a crest, our symbol of respect to our honorable a very token of love from our society and also department. First, there is a token of gift from Professor Rokeya madam to you. And also there is a gift from Department of Gynae and Obstetrics. Madam will leave tomorrow. Pray for her and all the best wishes for the madam, and come back soon. We will be very happy to see you again here. Thank you, madam. Thank you all the participants for remaining a whole day with us, and our scientific partner Nuvista. The whole team did a really excellent job. Please, a big clap, big hand for them. And also the Canon ultrasonography, Protim and are they here? Engineer Protim and Hasina.